So retinitis pigmentosa is a broad group of diseases that genetic by nature and cause vision problems. Today we use the term inherited retinal dystrophies or IRDs to encompass retinitis pigmentosa and others. So the others would typically include diseases like Leber congenital amaurosis, Stargardt macular degeneration, and others. And in a way, each of these has very different way they present the clinical symptoms with which people present and so on. So that's the broad group of diseases that we talk about: inherited retinal diseases, the genetic diseases that affect the retina. What is interesting is, of all the genetic diseases that can affect the eye, majority of them affect the retina. And that's where the importance of the disease and the diagnosis and all of that come in. So that's the group of disorders that we typically call as IRDs. So the symptoms with which these patients present differ according to what is the disease that we are looking into. For example, with retinitis pigmentosa, most people present with difficulties with night vision. A child has come from playing outside to inside the house and struggles a bit. Or one of the commonest symptoms that people face is when they walk into a movie theater that's already dark, struggling to find a seat. So these are some of the early symptoms that retinitis pigmentosa presents with. Difficulty with night vision. Now, this can start anytime in the first or second decade of life. But as the disease progresses, the difficulty they have is with, side vision. They may bump into people, they may bump into objects. They struggle to walk down a flight of stairs. That's because typically we are then looking at the lower field, which is now affected. So if you have a field of vision that is restricted, most of our lives is spent looking at our eye level and a little below. Because of that, what happens below the eye level becomes very, very important to a person. So they struggle to find the last step on the staircase, for example. Or, if a surface is uneven, uneven road and so on, they struggle to walk. So this difficulty with side vision is, what happens as the disease progresses. And in very advanced stages, of course, they would have tubular vision. And a small number of them lose all vision by their 40s or so. So that's retinitis pigmentosa. So there is a group of conditions called macular degeneration or Stargardt macular degeneration. This, in a way, is sort of works exactly the reverse way of retinitis pigmentosa. In Stargardt macular degeneration, the child starts struggling with central vision in the first decade or maybe by 15 years of age. So the child is not able to recognize letters on the board in the classroom, look at a slide at the distance and so on, whereas the rest of, they don't need to have any difficulties with night vision or the side vision difficulties. Their main difficulties is with the central vision. That's with Stargardt macular degeneration. Now, the other one that I mentioned was Leber congenital amaurosis, or it's called LCA. Now, LCA is the most severe form of all of these. Most children have symptoms by the time they are 2 or 3 years of age. It's recognized in infancy in many children. And this is one of the most severe forms of the disease, where a sizable number of them may lose all useful vision by the time they hit their second decade. So that's how the symptoms present across these three diseases mostly. There are similar diseases, like retinitis pigmentosa, but mostly these three are the ones that we, see commonly in India or the rest of the world. So with LCA, the parents do notice that the child is, not focusing on them and not able to recognize them. So LCA does get diagnosed, fairly early. And yes, the child is not saying much except that the parents would recognize and take the child to an eye specialist, and that's how the diagnosis is made with LCA. Now, with Stargardt, definitely, because the child would say that he or she is not able to see the letters in the classroom. That's the commonest presentation with Stargardt degeneration. Some of the difficulties with conditions like Stargardt and LCA can also be that, in the very early stages, when an eye specialist looks at the retina or does an eye examination, it's not very clear that the child actually has a problem. This is especially common with Stargardt macular degeneration, the early form. So there is, with Stargardt, there is a group that presents by 7, 8, 9 years of age, and there's a later onset. The later onset is quite clear because you see changes in the retina and so on. Whereas those that present very early, by the 7, 8 years of age, it's not very uncommon for the parents to be told that the child's eye looks completely normal, but the child is complaining of a problem. And so maybe we got to look at somewhere else. I've had a few children actually being referred to a psychiatrist saying that maybe the child is not able to cope in the class and so on, and there is nothing really what we call as organic inside the eye. When you find something in the eye that you can say that this is what is causing this, is called an organ disease. So there are children referred to for a mental health evaluation saying that the child probably is not able to cope. So this is unfortunately difficult with Stargardt's or sometimes LCA. Whereas with retinitis pigmentosa is quite clear. Two things with retinitis pigmentosa, even though RP is a group of diseases, the diagnosis per se is not very difficult because yes, the parents would notice that a child is struggling a bit in the night, and most of them also, I think, come up when the child starts bumping into objects and so on. This is one of the reasons why, especially with RP, the diagnosis is not made in most patients till they're in their 20s or so, late 20s, because that's when the visual field starts getting affected. That's when the person notices that, oh, I might have a problem. So many of them get diagnosis in their 20s with RP. So when in RP, at least, when an ophthalmologist does an eye examination, the diagnosis per se is not very difficult. So the eye is one area where imaging is very, very advanced, thankfully. And so today we have diagnostic techniques that, for example, does something that is similar to a CT scan of the brain. It's called an optical coherence tomography or an OCT. The OCT literally is able to tell us details of all the 10 layers of the retina. So there are 10 layers in the retina. The most important are 2 layers. One of them is called the photoreceptors or the rods and cones. And the rods and cones are like the building blocks that sit on a foundation called the retinal pigment epithelial cells. So they sit one on, one above the other. The rods and cones, below which is the retinal pigment epithelium. Now, so today we can do OCT in the outpatient. It's a very quick scan that's done. Takes less than 5 minutes, and that tells us the details of these layers at the central part of the retina, at the macula. So because of that, diagnosis is far more easier today. And then you have other diagnostic modalities. Of course, one, we do the photography of the eye itself, and then we examine the visual fields. There are objective ways of assessing the visual fields. It's called perimetry. Again, these are very easily available. And then the OCT, and there are a couple of others like fundus autofluorescence and so on. So these are mostly available in almost all ophthalmic setups. So because of that, it is not very difficult, at least, to understand there's something that's not okay in the eye. The difficulty is in LCA, where the eye examination itself could be normal. And so in most children with LCA, we do a testing called an electroretinogram. So when we talk about the fundus photo and the OCT and so on, we are looking at the structure of the retina. So to assess the function of the retina, there's a test called the electroretinogram. And in fact, it's done in almost anyone who presents with these genetic diseases. So an ERG helps in being able to tell us what the functioning of the retina is. So, for example, in a child with, let's say, retinitis pigmentosa, because here is a disease that affects the rods first more than the cones. So some parts of the ERG get affected. In an LCA, for example, both the rods and cones get affected. So in a nutshell, it's not very difficult to make a diagnosis. The trouble is only with LCA, where sometimes we have to do an ERG under anesthesia. Because in an adult, an ERG is done as an outpatient setting, whereas in a child, we may need to do an ERG under put the child, give the child general anesthesia, and then do the ERG. So that's a little bit challenging. So those are the ways that we really diagnose what is happening clinically. This is now called the phenotype. So whatever is the clinical information, we call it the phenotype, in a given person. Now, what is challenging is actually the genotype. To understand what is the underlying genetic problem that the person carries. I'll just take a step back to understand what is it that we're talking about when we say genetic testing. So if you look at if we look at the entire human body is made up of cells, and the cells have genetic material called DNA. So the DNA actually carries a series of spellings or nucleotides. 3 of these nucleotides get together to form an amino acid, and these amino acids then get together to form proteins. Now, if we test all of us, each of us will carry spelling mistakes on these nucleotides. And that spelling mistake is called a mutation. So most mutations are harmless, but when the mutation occurs in an area of the gene that is useful for our day-to-day function, because, for example, in retinitis pigmentosa, there are over 200 genes that have been identified that can have mutations. So if we have a mutation that is very important for some functioning of the retina, and more importantly, if we end up carrying 2 copies of the mutation, that's when trouble begins with the mutation. Now, we all carry 2 copies of each gene. One comes from the mother, one comes from the father. This is very true, especially for the 22 sets of autosomes that we have. Now, for the sex chromosomes, you have the X and Y, whereas for the autosomes, you have 2 copies, one from each parent. Now, especially in families in southern India, there is still a concept of, while we have come out of the concept of consanguineous marriages, mostly, at least in the urban population, in the rural population, marriages within families is still the norm. So what happens here is the same mutation is running in multiple members of the family. So, for example, one of the marriages that is common is an uncle-niece marriage. The maternal uncle and the niece marriage is still prevalent in the rural population. So both of these, the uncle and the niece, carry the same mutation. Now, when 2 such people have a child, they have a chance of giving, unfortunately, the mutation carrying gene to the child, who ends up now carrying 2 copies of the mutation. So that's when the child gets affected or manifests the symptoms, because this is one of the very common questions that I am asked, saying, nobody in the family has this condition, doctor. How did my child end up getting this disease? Or how did I end up getting the disease when no one else has this? This is exactly how it happens. That both the parents are carrying 1 copy, but because they have another normal copy, they never really show up the clinical symptoms. Whereas when someone gets both the copies, they end up with the clinical symptoms. So these are called autosomal recessive diseases, and is one of the commonest ways that a retinal disease at least transmit across generations. There are other ways which are not very common with RP or LCA Stargardt's. The commonest is the autosomal recessive mutation. So what do we now do in the lab? The lab will collect about 5 to 8 ml of blood sample, and then isolate the DNA and actually look for the mutation that the person may be carrying. Of course, the lab also will talk to the clinician to understand. So if we have identified this specific mutation, is this something that correlates with what you're saying, what the clinician is, saying, and so on. So finally, they will release the results saying that this is a mutation report of the person. Now, why is this useful? One, it will help us establish, how severe the mutation is. Because to be able to tell someone that, look, you don't have a very severe mutation, you'll be able to manage your life till your 50s or 60s, is hugely different from having to tell them you have a severe mutation or your child has severe mutation where there could be severe vision loss by the time they are 20. So that level of being able to prognosticate or sort of talk about the progression is very, very, very crucial for an affected person. So that's one. The second, of course, the population where we identify mutations mostly are where families want a couple wants to expand their family. That's one of the commonest reasons why people come for genetic testing. Either I have a problem, my wife has a problem, or someone else has a problem, and therefore I'm worried. Or they have one child with a problem, and they now want to make sure that the next child does not get affected. So these are reasons why we, do a genetic testing, even if we're not able to offer an immediate treatment. One of the biggest challenges is because the diagnosis is not very difficult, clinically at least, majority of them are given a statement saying that, oh, you have RP and you're going to go blind. That's a devastating statement for a person to take. So the truth is that majority of people with RP will not go completely blind. They may lose driving vision, they may lose the vision, not being able to navigate themselves for sure, but it's only a small percentage that becomes completely blind with RP. So I have several patients who into their 50s have difficulties, but they still are able to manage with the tunnel vision they have and so on. The biggest challenge with this is while the vision loss and its attending problems is of course an unfathomable problem that the parents face, it's also a social problem. Now, what happens when a person's visual field reduces is that if I'm in a social setting and then I'm talking to a group of people, which about, let's say, 4 or 5 people, because of my restricted field of vision, I may only be able to identify one or two of them. I don't realize that there are more than one or two in that group. So especially in a country like India, where social structures or social functions and all of these are very prominent amongst our culture, I have hundreds of my patients who refuse to go into a wedding, refuse to go and socialize because, oh, they're going to tell me that you looked at me, but you didn't say hello to me. This is a very common problem that these patients face. Mostly because, unfortunately, there continues to be a taboo attached to this disease and blindness in general in India. So, to give you the scale, for every one person who's completely blind, there are 3 people who are visually impaired. And I think, in a way, as a society, we would probably stop to help someone who appears to be completely blind, whereas for someone who appears to be healthy, because see, people with with RP or Stargardt's and so on, they don't appear blind. They're not struggling for navigating and so on, and so they do not appear that they have a major visual handicap. So most of my patients don't even tell their relatives, they don't tell their place of work that they do have a problem. So they continue to struggle with the limitations that they have. So this is the first thing to make them understand that it's okay first to accept the fact that there is a problem and then be able to sort of talk about it, ask for help. I think counseling plays such a huge role in helping people with RP and Stargardt's manage their lives better. This continues to be a social problem. So this is the first thing that we sort of talk about when we see patients with these diseases. It is not just about how much of glasses I can give and so on. It's also about trying to make them understand that this is not the end of the road. The
Okay.
other setting where people really struggle is with marriages. I have several patients where the parents will insist and get the girl or the boy married, saying that if we tell the other people that you have a visual handicap, you have a visual problem, then the marriage will never take place. So let's go ahead and then just get the marriage done. Trouble starts immediately after. It's not very difficult for someone living with a person with visual impairment to understand that there is something not okay. So this is as much a social problem as it is a visual problem or lifestyle related problem. So these are the ways that we actually have to counsel them, talking about acceptance, talking, being able to talk to others about their eye condition, seeking help. Unfortunately, our country is not really geared to help people with visual handicap, or for that matter, most handicaps. So I've had patients tell me that we've come to the other side of your hospital and we're not able to cross the road because, when I look normal and I ask for help, someone says, why are you asking for help? I have patients who go into airports and struggle because today across the world, it's all silent airports. I have patients who routinely miss their flights because they couldn't identify that the gate has changed, and so they miss their flight. I've had a few patients now who actually carry a letter from me saying that they are severely visually handicapped and if they could be helped. Because when you walk up to a help desk and you appear completely normal and you ask for help, the other person is completely puzzled. You look, okay, why are you asking for help? So some of my patients, I actually tell them, please wear a completely dark glass, carry a letter saying that I'm visually handicapped. So it's easy to ask for help. So it is a huge social problem. So while we don't have anything that we can offer immediately as a treatment, except for one, I will talk about it because today there is gene therapy available for a very specific mutation. I'll talk about it. So invariably, there is no treatment that's available today. So some of the things that we are aware is that low vision devices does help significantly in helping their lives get better. Many of them don't, just by the correct glasses, magnifiers, or today with the phone, the accessibility options that we have, wonderful on the phone. So many of them are not aware. So that is something that they can use. So in terms of actually advising what they can do, one of the things that we do know that the people should avoid is a exposure to a lot of sunlight, especially with people living in really hot countries. We advise that they constantly keep their eyes shielded, either by using a dark glasses or by wearing a cap, depending on whatever they're doing. So this is something that we advise. In fact, I even advise most of my kids that they're allowed to wear these glasses when they're in a classroom. Most of them do well with what we call photochromatic glasses, which sort of turns dark when they step out and sort of becomes white when they step back into a classroom. So that's one. The second thing is avoiding smoking. So nicotine is hugely detrimental to the health of the retina and the macula. And so that's one thing which I tell all of my patients across, that they have to reduce or stop exposure to nicotine, to the extent that it's not a great idea to even have an exposure to passive smoking. So exposure to bright sunlight and exposure to nicotine are two things that we have to avoid. There has been a lot of discussion about using oral vitamin A supplements. As a rule, I do not advise people to use vitamin A because we are still not very sure whether excessive vitamin A is beneficial. Whereas on the other hand, we know that excessive vitamin A can be very detrimental otherwise. So I generally do not recommend oral vitamin A supplements. There are people who use oral supplements of what we call antioxidants. The role of that is still very doubtful, And I would rather that patients have it in the natural form in terms of food, rather than have oral antioxidants as supplements. So avoiding exposure to bright sunlight, avoiding nicotine, and trying as much as of low visual enhancement devices that is possible. For example, many of these patients, while in retinitis pigmentosa we talk about the difficulties with night vision, many of them also have difficulty with very bright lights. So most of them do very well for our routine laptop use. Instead of having a white background and black letters, most of them do very well with the black background, either white or yellow letters on it, or being able to use magnifiers. In fact, I suggest many of them that they have touch screens, because one of the biggest challenges that, for example, software professionals with these eye conditions have is they struggle to find the cursor. If you have a touch screen and you touch somewhere and you have where the cursor is, so these are small things that help tremendously in their day-to-day life. And while some of them continue to drive, depends of course on the amount of visual field they have. Once they know that visual field is affected, I advise them very strongly that it's better that they avoid driving. And thanks to all of the Ubers and the Olas that we have, that's doable today in a country like India. The last thing that I typically do is, we unfortunately do not have any specific support groups for these diseases. So what I have done is to sort of get them created across my own patients. So for example, if I have a child with LCA, I will connect them to another father or mother with a child with LCA. So it's so much easier if you have the support of someone who's going through a similar problem. A couple of my patients, for example, are software professionals with children with these problems, and so they are very, very, very happy to be part of trying to help out others. So when I talk to a patient of mine, if I find that he or she needs help, I immediately connect them to another person, and make sure that they at least meet once or twice, so that the social anxiety is at least I help them try overcome to some extent. So the support groups play a very, very big role. There are organizations, for example, there is the ORDI, Organization for Rare Diseases India, which is trying to do this at a very huge scale. They are doing this mostly, I think, for non-ophthalmic diseases at a higher level. But with ophthalmic diseases, we don't have any specific support groups, unfortunately. At least that is recognized as society and so on. But this is what I do: connect them to my own patients so that they're able to sort of in some way understand how to navigate through life. So in the Western population, retinitis pigmentosa was known to be about 1 in 4,000 children born, whereas in India is higher than 1 in 1,000. And again, with Stargardt macular degeneration, Western population is about 1 in 10,000. We definitely have a lot more. We don't have, unfortunately, any prevalence studies with the Stargardt or LCA in India, but it's very high. In fact, it's so high that they do not even fit into the diagnosis of a rare disease. While I spoke about marriages within families, the consanguineous marriages, even if that is no longer very prevalent in the urban population, we still have what are called endogamous marriages. That means we still marry within the same caste, same subcaste. That's very, very highly prevalent in India still. So that's the other reason why we have a much higher number. Having said that, only in about 50% of patients do I see consanguinity. The others are really not. And so I think it's also the sheer numbers that we have. We're the most populous nation on this planet. So we are bound to have large numbers of any disease. So like I was saying, in autosomal recessive diseases, which is the most prevalent in India, it is about 25%. 1 in 4 chance the child has, is going to be born with a problem. The challenge is not just that we now have a risk of 25%. The challenge is to identify, is this risk now 100%? I have one child with a problem. Can I make sure that I do not have another child with this problem? Or mine. Now, unfortunately, many of them come when the woman is already pregnant, and then saying that either I have one child with a problem, or my husband or I, one of us have a problem. Now, it is very difficult to really help them at that stage when the woman has already come in pregnant, especially if she's in the 3rd or 4th month of pregnancy, simply because what is the ideal situation is to be able to understand what the mutation is running in the family, either before they have one child is the ideal, or if they already have one child, come in before they are pregnant again, because you need time to understand what is the mutation that the sibling or the parent is carrying, and then to be able to prognosticate what is the risk for the other child. So today, if woman comes, if we already know the mutation, today within 12 weeks of pregnancy, we are able to test the fetus and understand whether there is a risk of the second child carrying the mutation. But this is provided we already have the mutation known. The trouble with eye diseases is that even in conditions where there is a risk for life, the decision is fairly straightforward for the parents to make. Whereas when you have a child with only an eye problem, the decision of whether to continue the pregnancy or not is a very difficult one to make. So it is ideal that they already know that what the mutation is. So what is done today, which is technically possible, is to actually have an IVF done, an in vitro fertilization, and identify the mutation in the embryo, and then only implant the embryos that are mutation free. I'm sure this is not something that's done very, very routinely across, but this is technically possible and is being done in centers in India. So it's definitely possible to avoid another child carrying the same mutation in the family. But that's provided we already have, mutation identified. So this is why I said that most of these families that come to me for advice are those that are either planning for a family, or they already have one child with the problem and they want to have another child who's unaffected. I think being able to accept socially that visual handicap is a part of living for many people, and we are willing to accept someone who's, if they have a physical handicap, we are willing to help them, or we're willing to accept that. Whereas vision handicap, and I think to some extent even a hearing handicap, is not very easily acceptable across. I think it just takes a lot more education and awareness to understand that this is not something the person has a control over. So especially when we talk about recessive diseases, where one of the each parent carries a copy and the child has 2 copies, one of the major problems that parents go through is guilt. Oh, we both carried a copy and we give it to a child, and my child has a problem. So that guilt is a major factor to be addressed too amongst parents. So I think we need this to be addressed at several levels, starting from the primary ophthalmologist who is going to see the person for the first time, to be empathetic towards what's happening, to be not telling them right away that, oh, your life is done, you're going to go blind. Because that may not be the case really. Starting from the primary ophthalmologist to the caretakers, to be able to bring up a child with the confidence that You do have an eye problem, but this is something that you can live with and still be able to make something out of your life. To the schools, schools are schools play a major role in shaping a child's outlook in life. So while in cities like Bangalore, I don't think I've had any problems where children are asked to leave and so on. So most schools are very, very, very understanding. And of course, many a times I do give a letter to the school saying that the child does have an eye problem. So please help him or her cope. Make sure the child is able to made to sit in the in the middle, in the first bench, and if need be, if he or she can be helped with their schoolwork, classwork, homework, and so on. This is still a huge problem in people who come in from smaller cities. The school just feels we are not able to cope with this child, and the parents are told, please, can you take your child off the school? So awareness at every step, starting with the family, the caregivers, the school, and then creating the social support structures. So genetic testing, for example, is very, very expensive in India even today. So if we were able to have a genetic testing at much cheaper cost, and then being able to provide them with low vision aids, any aids to enhance their existing vision and help them utilize their existing vision, and social support groups. So there are multiple stakeholders across to really create a very useful support group. And if each of these can be tackled individually, and we all collectively come in to take care of this, I think we're going to make the lives of all of these people so much better. So that way, at least the patients also don't have to feel hesitant to say that, oh, I do have an eye problem. Today, I mentioned that we have about 200 mutations that cause retinitis pigmentosa. One of them that causes both LCA and RP is a mutation called RPE65. So there is a approved therapy as a gene therapy only for this specific condition. This is has already been approved in the US and across many countries in Europe. And I think we are on the verge of it getting an approval in the next couple of months, in India too. So what it involves is actually a surgical procedure and injecting this product of the drug. It's called Luxturna, under the retina. It's a surgical procedure. The challenge with this is it is very expensive. So in the US, it costs about $450,000 for a 0.03 ml of the injection. And it's on a similar cost in Europe. I don't know what price point is going to be launched in India, but I'm aware that it's going to be launched, very soon in India. So that's the only and only one that has any approved therapy in terms of gene therapy. So what is done in gene therapy is they use a virus as a carrier. It's called a viral vector. And the correct gene is introduced in that viral vector, and that is then injected under the retina, so where the virus can continue to replicate, for a while. So that then corrects the, underlying mutation of RP65. So this is in terms of gene therapy. As we speak, there are many, many clinical trials for other mutations for gene therapies, but there is no other approved gene therapy, as of now. The second is stem cell therapies. I get many queries about stem cell therapies. And while in gene therapy, we're correcting the mutation, in stem cell therapy, what we're trying to do is to replace the cells that are damaged. So replacing the retinal pigment epithelium and then the rods and cones. This is a science that is very, very difficult. So across the world, there are a few companies, organizations that are working on trying to replace the retinal pigment epithelium alone. There are probably two or three that are trying to work on the photoreceptors, but science has not reached a point where we can actually combine these, rods and cones and the red pigment epithelium and then inject it under the retina. I have many, many queries that come in saying that I have been promised stem cell therapy. Can I go and get it done? So there is no approved stem cell therapy for retinitis pigmentosa or any genetic disease of the eye anywhere in the world. There is a similar condition called age-related macular degeneration or AMD that happens in older people where the central macula starts degenerating, and there we can try replace retinal pigment epithelium because that is a culprit in AMD. That's the main culprit in AMD, and so we try replacing the RPE cells in AMD. But in conditions like retinitis pigmentosa and so on, we cannot replace both the layers as of now. So even with the RPE, there are no approved therapies. There are only clinical trials. So that is something that people should understand, that while I'm aware that there are clinics that are offering stem cell therapies, there is no approved therapy as of now anywhere in India or the rest of the world.